Our next prominent and esteemed guest is a doctorate of medicine, PhD in hyperthermia as an immune system activator. She developed her professional work in the United States for several years after pioneering a technique to improve the treatment of breast cancer. Recognized in the United States as an extraordinary person in the sciences, a category awarded to Nobel Prize winners who carry out her work in the US, and her main researcher in the studies being developed with Oncothermia in Spanish public health. Let's put our hands together with Professor and Dr. Elisabeth ARROJO, MD, PhD, the lady in red.
Thank you, thank you. I'm going to check if I have something to point. Yes. Yeah, so thank you so much. First of all, I would like to say thank you to the organizers, to Oncotherm, for being always supporting our research. And I must say that this is a great opportunity for Philippines, because here I know you have very advanced tumors, and hyperthermia is especially good in those situations. So I think today is a great day. So let's see here. So today for me is also a brainstorming, because I am here with some of the best working with hyperthermia, and with all of you. I think we have to join knowledge in order to go on moving forward with the treatments. So I would like to show you some experiences to think about, because, for example, we have been speaking today about abscopal effect. That is something that they teach us as a radiation oncologist, that it exists as abscopal effect, but finally we never seen it in the clinically. So this is a patient I treated. You see here the mass. It was lung cancer with a vena cava syndrome. So we treated her with radiotherapy, 25 grays in 5 treatments, but we didn't treat this lesion here. This was before treatment, and this is after treatment. She was not under chemotherapy. So this is abscopal effect. So this is something very, very interesting to have into account. This is another patient. We treated her for a skin cancer from breast cancer. She had a relapse of the skin in the thoracic wall. So here she didn't receive radiotherapy, nor chemotherapy, nor anything. You see the isodose line of 5 grays, which is this one. She received 40 grays in 15 fractions. And this is after treatment. You see the node now is smaller. You see before and you see after the treatment. So again, abscopal effect. Abscopal effect is something very common when you combine radiotherapy plus hyperthermia. And this is very important to know. This is monotherapy. I was saying before that microcytic lung cancer has very good response when we treat in monotherapy. We were treating this patient in monotherapy because she didn't have any other options for chemotherapy. And you can see how was, the mass before the treatment and how was the mass after 12 treatments with hyperthermia. This is impressive. And she improved a lot clinically also. She also had liver metastases. We treated both parts, the lung and the belly. And you can see how the response was also very good after the hyperthermia treatment. This is another lung cancer treated with monotherapy. You can see it was an epidermoid lung cancer. It was a man, and this was the mass before treatment, and this is after treatment. You can see again a very good response. And after that response, the patient was candidate to immunotherapy. He is still alive after 3 years. So this response is really good. This is glioblastoma. I am the main investigator in a clinical trial in Spain, a randomized phase 3 trial comparing radiotherapy, chemotherapy plus oncothermia versus only chemotherapy and radiotherapy. We still didn't publish the results, but are being very, very good because survival is significantly improving. So we will publish that shortly. So here is monotherapy. This is a patient, 43-year-old female with IDH negative EBM, and you can see how was the tumor before treatment and how was after only 1 month of hyperthermia treatment. So this for me is impressive because we know that GBM doesn't respond to anything. So again, another case. This case, I treated him with radiotherapy combined with chemotherapy, the standard STUP protocol. And this was 1 month after retreatment. You see he had a tumor progression. So I decided to try to treat with modulated electrohyperthermia in monotherapy. And this is after 18 treatments, and the patient improved clinically significantly. So this is from Dr. Minar, the phase 3 trials he performed about cervical cancer. And in these trials, he also made another study about abscopal effect. And you can see how she also saw more significantly abscopal effect when she combined the treatment with hyperthermia, the standard treatment plus hyperthermia. So what I want to say is that when we use hyperthermia, it's not only something related to vasodilation and not only related to an increase in oxygen levels inside the tumors, but it's also related to something happening with the immune system. Because in cancer, we know immune system is the key. It's the key because immune system has to kill malignant cells, but it's not able to kill all the cells. So we have to know this. But we also have to know that we need to be very careful with immune system because treatments sometimes can decrease the immune system cells and it can decrease the response. So I think these are important tips. In radiotherapy, we know radiotherapy is the second most curative cancer treatment after surgery. We know that radiotherapy can be always lethal, but the problem is that we cannot give the high dose we need sometimes to kill the tumor without killing the patient because of side effects. But we also know that we need to have into account that high-dose radiotherapy can be very effective for the tumor, but can be bad for immune system. And low-dose radiotherapy is not enough for the tumor, but it is good for immune system. This is important to know and to know the potential combination of radiotherapy plus immunotherapy. We need to know that lymphocytes are very radiosensitive. When we treat with only 2 grays, 50% of circulating lymphocytes are destroyed with a very low dose. And we know that almost all our treatments have daily 2 grays fractions. So this is a big problem because that lymphopenia is going to decrease immune system response. So here you can see how when we treat the patient with radiotherapy, lymphocytes go down and they began recovering 1 month after retreatment. And we have studies showing that destroying those lymphocytes negatively impacts survival. The survival is significantly worse when we kill those lymphocytes. So we also know that radiotherapy can be very good to stimulate the immune system because it increases the antigen cell presentation with the dendritic cells, so it can have a very positive impact on immune system. And we have to know that maybe in order to do that, we need to do SBRT because we are giving like more or less the same dose, but in less fractions, so we are going to have a faster lymphocyte recovery. So SBRT and radiosurgery is really interesting for this. But as I said before, we have to be very careful because radiotherapy can also decrease the immune system efficacy. So what if we combine high and low dose radiotherapy to have better results? So let's try. So there are some publications about this. This is a publication from MD Anderson in Houston. They combine high dose and low dose radiotherapy to treat metastatic lesions after progression to immunotherapy. You can see that they included 74 patients, 39 received high-dose radiotherapy, and 35 combined high-dose radiotherapy plus low-dose radiotherapy. And they went on with the immunotherapy, but it was the immunotherapy they had already progressed to. So you can see that after retreatment, most of them continued with immunotherapy, but I remember all of you that the immunotherapy was not working before radiotherapy. So here you can see that the response seems better in the group combining high and low dose radiotherapy. The results are not significant, probably because the number of patients is too low. But if we look at the low dose lesions treated in the high dose and low dose group, you see that they have a very important response rate. With very low dose radiotherapy is non-lethal dose radiotherapy, so this is again like ASCOBAL. And if you see the non-radiator lesions have also a good response. Finally, in the high-dose alone group, they also have some response, but it's important that the low dose combined with the high dose have very good response. And also it's important that patients with better response was the ones with immunotherapy for 6 months before the treatment. So here you can see, I think this is very impressive. This is an example of one of the cases they published. They treated this patient is metastatic esophageal cancer that progressed to pembrolizumab. And you can see they treated the patient with 25 grays in 5 treatments to the sternum and then 7 grays in 5 fractions to the neck. You know that 7 grays in 5 fractions is almost nothing for radiotherapy. And you can see the response here. So the response is wonderful and the radiotherapy dose is really low. So you can also see how they analyze the immune infiltration inside the tumor and how there was a 300% increase in T4 and almost 200% increase in natural killer inside the tumor. So what happened is like high-dose radiotherapy starts to move the wheel in the immune system, and low-dose radiotherapy modulates and powers the response. So we have to know this because this opens a big field for improving results. So we also know that liver is a special organ because if you look at the literature, you can see how patients with liver metastasis treated with immunotherapy had worse response compared with metastasis at other sites. And this is interesting because the liver, the immunotherapy is limited by the unfavorable conditions of the liver. It has dense stroma, low rates of macrophages, so it's not like very good for immunotherapy. But when we treat with low-dose radiotherapy, we change that. So what we get, as you see here, is we increase T-cell infiltration a lot, so we can have better response when combined with immunotherapy. And this is with low-dose radiotherapy, a dose which is not toxic for the patient. This is another case they presented from MD Anderson. It was a melanoma. She had metastasis to the liver, lung, bone, brain. She didn't have any other options for systemic treatment, but they went on with nivolumab. She was progressing to nivolumab, but they went on with the treatment. So what they did is they treat this lung lesion with 50 grades in 4 fractions. You can see with SBRT here, and you can see the liver with a lot of metastases. The biggest one was 9.5 centimeters, and they treat the whole liver with 5.6 grades in 4 fractions. We know that is nothing in radiotherapy. So if you look here, you can see 4 months later, the patient had a fantastic response, but that is not all. 19 months later, there was no disease. So this is really, really impressive. So what can we do to improve this? Because we can improve this. We can have higher doses to the tumor without damaging the patient, and we can stimulate more immune system, and that is with hyperthermia. Because we know that hyperthermia is very helpful because tumors are very hypoxic. When we hit the tumor, we open the vessels, we increase oxygen, and this is very good. You know the enhancing effect of radiotherapy with oxygen because it fixes the damage to the DNA, so it's going to improve radiosensitivity. But it's also very important the acidity of the microenvironment. This is very important. This is a clinical trial, it's a meta-analysis from randomized trials which shows an improved survival in head and neck, breast cancer, and cervical cancer. And you can see how the biological equivalent dose when we add hyperthermia increase significantly. So we can give more radiotherapy dose without increasing the dose of radiotherapy, which can have better results without side effects. But as I said before, the microenvironment is very important. It has an important role on tumor progression. And tumor microenvironment is hostile to radiotherapy and also to chemotherapy because we know in radiotherapy it's important the dose we give, is also important the moment we radiate the cells because not all the phases on the cell cycle are the same radiosensitive. But it's also important to note that the microenvironment is also very important because when we have an acid microenvironment, you see how apoptosis is suppressed or is delayed. So the acid microenvironment is also bad for radiotherapy because it's going to suppress apoptosis. So if we increase the oxygen levels, we will decrease the acidity, we will have also better results. So there is something else about microenvironment. When we have hypoxia, it happens another important thing, is that it inhibits the dendritic cell maturation. So we are again suppressing immune system. So my partners were speaking before about the dendritic cell therapy, and this is one of the reasons why the dendritic cell therapy can fail because the oxygen levels are low and the dendritic cells cannot maturate. But if we combine the treatment with hyperthermia, we'll decrease the hypoxia and will allow the immune system to work better. So we need to move forward and increase these results combining with hyperthermia because, as I said before, radiotherapy can stimulate the immune system, but we know because we have evidences that hyperthermia can also stimulate the immune system in the same way. It can increase natural killers, T lymphocytes, and have better immune response. So what we have to do in this new era of immunotherapy is that we have to convert cold tumors in hot tumors which respond to immunotherapy. And we can do that with radiotherapy and with hyperthermia. So we need to know what we want to achieve. Maybe a local effect, killing the cells with high-dose radiotherapy, or maybe a systemic effect with low-dose radiotherapy plus the hyperthermia. So it was presented this trial before, because this trial is a very important one. In sarcomas in Europe, hyperthermia has evidence one and is in the guidelines for treating sarcomas. You can see how the survival here, this is a randomized trial where they compare chemotherapy alone or chemotherapy plus hyperthermia in sarcoma patients. And you can see how the survival was significantly better in the patients who received also hyperthermia, 9 years more, which is impressive. It was neoadjuvant treatment. But what I want to show you, it was not that, is this part of the study. Dr. Pirus said this morning, part of his results. They also did a new study, studying what happened with the immune system in these patients. So they have the biopsy at the beginning and they have the biopsy in the surgery. And what they did is they analyzed the infiltrating tumor lymphocytes to see what happened with CD8, also PD-1, PD-L1, and FOXP3. So they see that in both groups, chemotherapy alone versus chemotherapy plus hyperthermia, the infiltrate was comparable. But it's interesting to see how those patients with a high lymphocytes infiltration have significantly better local progression-free survival and disease-free survival. So it's important, this increase in immune cells. But it's more impressive also that the patients who had an increase in CD8 and received hyperthermia had significantly better local progression-free survival and disease-free survival. So adding hyperthermia increased the immune response significantly. So in patients with low CD8, there was no differences between the groups. So a high increase in CD8 adding hyperthermia significantly increased the results, and this is something very important we have to take into account, the immune effect of hyperthermia. So we need to increase CD8. Up to now, we knew that chemotherapy could do that, also chemotherapy, radiotherapy, but now we also now know that hyperthermia can also do that. This is a study we did at my center, at my clinic. We were treating different patients. This, for example, is a case with breast cancer with multiple brain metastases. And we were treating the patient with hypofractionated radiotherapy in the brain. So you can see here in red, these days the patient received in red radiotherapy and in green hyperthermia. So you see that we gave to the patient some more treatments after the radiotherapy treatment. And what we did is we analyzed peripheral blood levels of lymphocytes just before and after each hyperthermia treatment. And this is with the combination radiotherapy plus hyperthermia. You see that lymphocytes CD4 are more or less the same. And this is after finishing radiotherapy, when we did hyperthermia in monotherapy. You see that CD4 went down, and this is related with favorable prognosis. But when we analyze CD8, you see that there is a small decrease with radiotherapy. We know that the radiotherapy is killing lymphocytes. But what is interesting is what happened with hyperthermia in monotherapy. You see how with each treatment, lymphocyte CD8 increase. So for me, this is very interesting because we are stimulating immune system in monotherapy. And if we look at activated T lymphocytes, it's the same. In monotherapy with hyperthermia, we are increasing the lymphocytes, so we are stimulating immune system. There are almost no publications combining SBRT radiosurgery plus hyperthermia. I have the honor to say that we are, I think, the first, I always say the first like this because maybe there is something I don't know, but we are the first publishing radiosurgery plus modulated electrohyperthermia in the brain. We presented our results at the International Stereotactic Radiosurgery Society Congress 1 month ago, more or less. And this is very interesting because this is irradiation of high-grade gliomas combined with modulated electrohyperthermia. We are treating gliomas for the second or third time with radiotherapy because we use low dose and combine with modulated electrohyperthermia. So here you can see the abstract. There was 8 patients treated with 14 lesions. The median age was 48 years. The median of 2 lesions for each patient. And you see that we gave 1 fraction of 15 grays, 5 fractions of 25 or 23 grays. And still the follow-up is very short, but at 6 months, the survival was 67%, and these patients were patients without any other option, and we treated them for a second or third time with radiotherapy, so these results are really, really good. So we need to awake immune system and make its response huge, because that is going to help us. Now there are several studies using SBRT in patients with a lot of metastases. We have also done that. For example, we have treated 1 case, a 48-year-old man with colon cancer. We treated 15 lung metastases with SBRT, plus 2 liver metastases with SBRT. We combined the treatment with hyperthermia. 18 months later, the patient is with a stable disease and with no significant toxicities, and he didn't have any options almost 2 years ago. This is a breast cancer case. It's impressive because this patient, you can see the PET-CT before the treatment. She had nodes almost everywhere. And the interesting thing is that this patient received only 1 cycle with Taxol, pertuzumab, trastuzumab. Then she said she didn't want any more chemotherapy, and we went only with the immunotherapy and trastuzumab. And she received 29 hyperthermia treatments, and this is 2.5 months after treatment. So something is happening in the immune system because you don't see this response with the standard treatment. So I'm finishing now. This is another clinical case. It's a male, 62-year-old, stage 4 prostate cancer, Gleason 9. He had received a lot of treatments. There were no more options for treatments, and he had 14 liver metastases on MRI. So what we do here is we treated 13 liver metastases with 5 fractions of 1.4 grays, and 1 of the liver metastases with 5 fractions of 10 grays, concomitant with the hyperthermia, and you can see the results after the treatment. So here you can see post-treatment change, but only 1 liver lesion, and we had at the beginning 14 liver lesions. This is his PSA levels with significantly decrease. This is also interesting because it's a pancreatic cancer with liver metastases. He received a lot of chemotherapy treatments and had no more options. So what we did is more or less the same. We treated 2 lesions on the liver with 5 fractions of 10 grays and 9 lesions with 5 fractions of 1.4. We combined with modulated electrohyperthermia. You can see more or less the dosimetry here. And here you can see that after treatment, the patient had a stable disease. And finally, these patients lived 12 months more without treatment with a stable disease. And finally, he died from a peritoneal infection, but not related to the tumor. So this is impressive also. So this is another case, a melanoma who progressed to immunotherapy. She didn't have any options. And again, what we did is we treat almost all the liver, and we gave a boost to the bigger metastases. and she has a stable disease. 1 year after that, she is still alive, and now she is receiving nivolumab. This is my mom, and I'm going to finish with this because I was working in the US and I came back to Spain because my mom had melanoma. She had melanoma in 2015. You see the scar was terrible, but it was localized, no problem, so everything was okay. But what happened in 2019, she had her first brain metastasis. She had surgery, radiosurgery. Then she had more metastases. We began with immunotherapy. The side effects were very important, so we had to stop treatments, and suddenly there were no more options for treatment. That's when I moved back to Spain, and thanks to that, I began working with modulated electrohyperthermia to treat hair. What I did is I treat all the lesions with radiosurgery with 23 grays at every lesion. I combine the treatment with modulated electrohyperthermia. I open my own clinic only to do that, to treat my mom. And you can see my mom now, his hair. I have a street in my city also after the results we get with the, yeah, thank you. Thank you. And she had more than 12 distant metastases, and what I did is treating with radiotherapy because we know that systemic disease can also be controlled with radiotherapy if we cannot do any other things. She had 5 brain metastases at other places, and now she is free of disease 5 years after that. So this is the clinic, one of the centers I worked in Spain. This is the clinic I opened. It was smaller, now it's bigger. You are invited to visit us. We have a clinic in Madrid, Bilbao, and I also work at a public hospital in Santander. And to finish, that we know the key is the cure for curing cancer is immune system. And we have to know that radiotherapy and hyperthermia and local treatments, but with systemic effect, and this is very important. We have to have all the tools for treating patients because that way we will have better results. And nothing else. Thank you so much, and if you have any questions. No questions.
What an extraordinary deliberation by Professor and Dr. Elisabeth ARROJO, MD, PhD. Thank you, Doctor. Nobel Prize winner indeed.
Okay, the doctor is very shy. Anyway, Dr. Despabiladeras is from Fabella. She is an OB-GYN consultant. She is with our hospital. And I'm about to refer to her a malignant teratoma. And I will be asking you, do you have experience with the teratomas, malignant teratomas?
I have only treated one because are not so common, but I studied a lot before treating the patient. And as Dr. Minar said before, the most malignant tumors, the most aggressive tumors usually respond like better because they are more hypoxic and the treatment works very well. So there is no side effects with hyperthermia, so you don't have anything to lose, and it can improve the treatment because the problem many times is that the vessels are so bad inside the tumor that the treatment is not going to arrive inside easily. So I think hyperthermia can add better results to the treatment.
Okay, thank you, doctor.
Thank you.